So results is mostly related to how when you plan the treatment. So this is obviously maxilla. So maxilla is attached, as you all know, various bones. Like zygoma is there, nasal bone is there, orbit is there. Ranaki has said that see almost all the surgical, all things in orthognathic surgery can be managed by 5 procedures. One is default one, second is anterior maxillary osteotomy, third is PSSO, genioplasty, and suburban. Or if you are able to do these 5 procedures, I think almost entire thing can be managed by you. This is the structure of the maxilla. So regarding maxillary osteotomies, so you have to know various vital structures, where exactly it is. So one is obviously the nasolacrimal tract. It's merely positioned about 10 to 14 millimeters posterior from the piriform aperture and 10 to 21 millimeters from the nasal floor. So when you doing the procedures, somewhere near to that, so you have to be very careful regarding the damage to the nasolacrimal tract when you are doing a high maxillary osteotomies. Another important structure, it can be a nightmare, that is during the pterygomaxillary dissection, where you'll be encountering which artery? Internal maxillary artery. So you have to be very careful. There's a descending palatine artery, medially 10 millimeters from the maxillary for tuberosity. So while chiseling, you have to be very careful. So this is, you can see where it's at the nasolacrimal duct is the position of the nasolacrimal duct. Another important aspect is the vascularity of the maxilla. See, suppose if you are doing the procedure, you are down fracturing the maxilla. So obviously, what happens? There's a damage to the nasal palatine artery and the greater palatine artery. Sometimes the both arteries get damaged. Still, you feel that the maxilla survives. Why? Because it gets supply from exactly. You are getting supply from the ascending palatine artery as well as the ascending pharyngeal artery, and you can see that supply comes down. You understood? So suppose that's why. Suppose if you get a damage from while you are obviously during the fracturing. I think this is the neck. Hello? Okay, fine. Done. So that's right, you can see it gets the supply from the ascending pharyngeal as well as the ascending palatine artery. So, see, while you are getting default by doing maxilla, so it's a nightmare to start because sir will be talking regarding the complications. So he'll be talking the details regarding such things. Then just saying this thing. And the important structure is where the tertiary plexus of Peale. So you have to be very careful when you are dissecting going posteriorly. You have to be careful regarding the pterygoid plexus vein, which is located between the temporalis and the lateral pterygoid muscles. Obviously, the vascularity was well studied by Bell. So, restoration, how it's well studied extensively in 1995, like restoration of blood supply 1 week post-operatively, and 1 week there's an increase in the periosteal and endosteal supply, 2 weeks, then vessels connecting segments, and 4 weeks blood circulation in the segments. These are the osteotomies. Variations are there. Mainly, you can get the maxillary osteotomies. Variations are there. Lefort 1, Lefort 2, Lefort 3. Then horseshoe is there. Anterior segment is there. Posterior segment is there. So, another is the biological basis of the anterior segmental osteotomy. See, it was studied by Bell. So, here it is extremely critical where you have to be very careful in handling anterior maxillary osteotomy. When you are doing Lefort, usually you do Lefort 1 osteotomy along with anterior maxillary osteotomy. So, you have to be very careful while doing the anterior maxillary osteotomy because you have to be very careful how you are going to manage the pedicle. Because you are getting supply from the various aspects like the nasal area, palatal area, etc. But pedicles you have to be very careful in managing it. So these are the various procedures by doing the anterior maxillary osteotomy. By Cone is there, Weismuth is there, Cole, Bell, Kerwin. So many people are well studied on this. This was the thing which anterior maxillary osteotomy was first done. So, Weismuth is there. Some people you use a palatal cut. Some people use a buccal cut. Some people use a tunneling procedures for doing the procedure. This is like you can see a Weismuth procedure. This is how the cut is made in the palatal aspects. Here, Copper's method, where buccal flap is laid and palatal osteotomy is made by tunneling. You are not putting an incision on the palate. You are putting a buccal incision, doing a buccal cuts and all, and palatal area will be tunneling and process. So palatal flap is maintained here. This is another modifications by Werders. Werders method involves a palatal flap raised by a transverse incision. So this you are putting a transverse incision in the palatal aspect. So we have to be very careful. But there's a buccal supply intact. So either you have to get a buccal supply or a palatal supply. One thing definitely should be there. That is absolutely you have to be sure. Somehow you have to maintain the supply, especially when you are doing an anterior maxillary osteotomy along with Lefort 1 osteotomy. While you are doing the tunneling, you are down fracturing. Once you are down fractured the Lefort 1, especially if you are not tunneling properly, what will happen that this palatal flap will stick onto the bone. So you are down fractured in the anterior maxilla, what will happen? There can be a tear in that area. So you have to be very careful while doing the anterior method. And doing do a buccal area when you are approaching, you have to keep that buccal pedicle intact. Because when you are stretching, there's every chance that there can be a tear of that area. So to be very careful. So these are mostly what you do for anterior maxillary osteotomy. See, it is used for the correction of the bimaxillary protrusion, marked protrusion of the maxillary teeth, anterior upper bite definitely, and definitely you have to portray improvement in the appearance. And there are cases where orthodontic treatment is at ankylosis surgeries are there. Complications, definitely, this have to be very careful regarding loss of vitality of the dentition, damage to the tooth root. Obviously, you have to always better to go 5 millimeters above, but certain aspects it might not be able to get 5 millimeters. See, when you approach the canine area length will be quite long, and obviously when you are cutting, it is not possible mostly to get 5 millimeters. Obviously, it is better to say 1 centimeter, but of 1 centimeter is impossible in most cases. 5 millimeters, yes, definitely, but certain cases when you are going the canine area, it is not possible. Damage, especially the damage of the two roots. Which root mostly? Canine, yes. Canine and which premolar? No, first premolar will be all extracted. For academic maxillary osteotomy, most of cases the first premolar has been extracted, but certain cases you can go for second premolar, but first premolar is extracted. So mostly it is the canine as well as the second premolar. Osseous necrosis of the left osseous segment, it can be a real nightmare because patient comes for an orthognathic surgery, cosmetic problem, land up with necrosis, really a nightmare. Oronasal fistulas, rhinitis, communication with the nasal as well as nasal cavity as well as the maxillary side. Okay. So another thing is that during anterior maxillary osteotomy, two things you have to be very careful. One thing is you are pushing the maxilla backward, and certain times what happens, which will be obstructing where the problem happens, go the nasal area. So you have to be very careful in reducing the nasal area part. So either you are going back as well as sometimes you will have to push through. It will be there is a problem with the nasal floor area. So you have to focus on the ALR. What is ALR sitting? Yes, you are? Yes, how do you do? Okay, so you will be putting a cinch to reduce the wider area. Then obviously you can go for a V-Y closure. Posterior osteotomies. There are certain cases with alveolar hypoplasia or a total maxillary hypoplasia where it is combined with the anterior maxillary osteotomy. Definitely, with the spacing in the dentition, transverse excess or deficiency, anterior occipite as well as the posterior cross-balance. This is how you do it. Kofner technique is there, Bell's technique is there, and combination of anterior and maxillary osteotomy is called the horseshoe osteotomy, where it will be combining the anterior as well as the maxillary osteotomy. And that is the common procedure of default osteotomy. Can you say what are the steps of default osteotomy? First of all, when doing a default osteotomy, you have to what are the plans, whether you are going for a maxillary excess or a maxillary deficiency or a gummy smell. These are the procedures where most procedures where you are all the club cases you are going to do a maxillary osteotomy. So whether it's a normal default one or a high default, or there are variations of default ones, default 2 or default 3, but mostly we do default 1 only, default 1 as well as the variations of high default 1, where you have to be careful about the previously said about the nasal lateral tag. So first is you have to put an incision. Yes, you will start from vestibular incision. Yes, you will start from the vestibule up to first molar, around 5 millimeters superior. So you have to put an incision, and as soon as you reach the posterior aspect, you have to go in the subperiosteal. Why? Yes. What happens? There's a damage of the buccal pad of fat, and it can be a nuisance for you. You understood? So you will do the bilateral incisions, expose it. Next step, Next step, you have exposed it from 6 to 6. Tunnel back, you can get the tuberosity area. Yes. Next is, yeah, you raise up the pyriform. Pyriform aperture, you have to raise it. Next is, next. Exactly what? You have to descend the nasal mucosa. Bilaterally, you have to descend the nasal mucosa with some ovaperiosteal, all those things. You have to reflect it. Then what is the next step? You have to guard the nasal floor. So you have to keep a periosteal for guarding it. And you start the how much amount or how much you are planning for removal. Suppose if you need a 5 of excess that has to be removed or 7 excess, you have to remove. You take a measure and you take scale or you enter mark 5 meters or 7 millimeters. You remove the bone. How much you have? One is how. Once superior compartment is there, inferior compartment is there, you remove the bone on the bilateral aspect. You understood that till how you are going to do. One way is that removing the heat posteriorly and from posteriorly you can remove it or through the pterygoid. You understood? So normal is through the you bring the pterygoid. So you remove bilaterally. Next step is see lateral osteotomy. Is that actually that's a preference? I don't do osteotomy immediately. Why? Because while doing the lateral osteotomy, there is a chance of damage to the vessels and it can be bleeding. So okay, you can proceed with the lateral osteotomy. You have the left and the right side, because two sides are there. You understood that the guard is there. The guard is there for supporting the nasal floor. So you do a lateral nasal cut. Then the septum cuts, mid septum cuts. The septum incision, the mid area you cut posteriorly. Then what is the last step? Pterygoid dissection. And which direction you dissection in? Never go back and the upward direction. You should always the downward direction. Obviously, sir will be talking regarding that thing. You have to down fracture it. Then after down fracturing, you have to be, especially when you are going for a superior lifting, you have to do a proper posterior reduction. Otherwise, you might not be able to get a proper lift. So you have to be careful regarding that. This is the procedures of the osteotomy. That's to correct the various maxillofacial problem, advancement left back or already said. Superior reposition of the maxilla, inferior reposition of the maxilla, widening of the maxilla, and all instances like that, open bites, you have this. Then this is the procedure. Sorry. So again, this is a complication that will be saying I'm unfavorable osteotomies, trigeminal cardioreflex regarding down fracture, bleeding, obviously, persistent bleeding, that kind of thing. This is comes from the orthodontic part for what is called the surgically assisted maxillary expansion. What is this surgically assisted maxillary expansion? Yes, there will be the cuts. Currently, which direction? Where it is given in the pit. Back with parallel. split. So this is the cases where skeletal maxillary transfer discrepancy greater than 5 mm. Significant cranial associated with the narrow maxilla and right mandible, failed orthodontic expansion, obviously, large amount expansion, cerebellum, extremely gingival tissues, and widened arch collapse associated with the cleft deformities. These are cases, the variations of the default one. That is from the conventional, you will be diverting from the conventional one, you will be doing a high default one, or certain cases, in case of there is a maxillary or zygomatic area deficiency, you can take a bone from the, like a, or involved with the zygomatic area also, like the quadrilateral area, you can take it and bring forward. So default 2 osteotomies. See, default 2 and default 3, this type of cases you will be more doing. Okay, mostly default 1, default 3, default 2 and default 3 will be the syndromic cases. Indication in maxillary zygomatic deficiency with skeletal class 3 or nasomaxillary deficiency with default osteotomy or cleft deformity or normal nasal process. There's something called the anterior default 2 and the posterior default 2. Default 2, where will you putting an incision? Default 2 incision. Yes. Front of incision. Good. Then, yes, from the medial aspect of the very good. Infra or anterior. Then, obviously, you look at the intra incision and take split of the tail. Complications again, default and not going cerebrally taking mainly it is diplopia and ophthalmosis and infraorbital nerve dysfunctions. Default 3 osteotomy again will be going with the, can you name some syndromes where you will be needing a default 3 of your osteotomy? It's written there. What? Apert syndrome, Grosset syndrome, all these cases, ideally, default 3 is the treatment of choice, but to do a default 3 osteotomy is difficult, so we manage with high default 1 or quadrilateral type of default product, but ideally, you need a default 3. But we do with high default or grafts, take some graft and now we have so many implants also are there, we can manage like that. Surgical approach is subcranial, extracranial approach. Classical default 3, medial catheter ligament, lateral region, lower angle incision, intraoral vestibular incision, or a coronal incision. Obviously, the intraoral circus incision bilateral. So either you have to circumferential dissection has to be done around the organ, and mobilization of the periorbital osteotomy approximately 10 millimeters inside the orbital margin. Osteotomies. Orthodontic inferior to the retronasal suture, extended posteriorly into the orbit behind the nasolacrimal, extended inferiorly and laterally towards the region of the intraorbital and orbital osteotomy that laterally towards the intraorbital. So this is osteometers, that is orbital for osteotomy direct laterally towards the infraorbital fissure.